So I actually realized that I did a video on cholera, I've done a video on enteric fever or salmonella, but I actually haven't done a video on diarrheal disease. I even did a video on dehydration. I will leave it tagged at the end of this particular video for those that haven't watched that particular video, as well as one for fluid management in pediatric patients. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at diarrheal disease. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon so you should be receiving notifications of such amazing content every time I post. Drop a like, drop a comment. To Zambia and beyond, let's go. So remember that diarrhea is going to be defined as the change in consistency and frequency of the stool. It becomes liquid or watery stool occurring more than 3 times a day. This definition here, I don't really like it because there are some individuals that go to the toilet maybe once in, let's say, maybe 3 days, or maybe once in 4 days. There are some individuals that go maybe 3 or 4 times a day. So this definition is not really highly individualized because different people have different bowel habits. A much better definition would be an increase in the water content of the stool above the normal for that particular individual, which is approximately 10 mL per kg per day in infants and young children, as well as 200 grams per day in teenagers as well as adults. And remember that often this diarrhea is going to be due to an imbalance in the physiology of small as well as the large intestines. These are going to be involved in both absorption of different ions, absorption of organic substrates, and therefore absorption of water. If the diarrhea consists of blood in it, we call that as dysentery. I will cover a video today because I'll release 2 videos for this particular channel. In the next video, we'll talk about dysentery. So there is a term that I want you to know. One of them is known as acute gastroenteritis. Another term is known as acute diarrheal disease. I've seen some clinicians actually, if a patient has vomiting and diarrhea, they say that they have AGE, acute gastroenteritis. If a patient has diarrhea alone, they have what is known as acute diarrheal disease, or ADD. So even though we use the term AGE or acute gastroenteritis commonly to mean synonymously with acute diarrhea, acute gastroenteritis in itself is actually a misnomer. Because if we look at the term gastro, meaning stomach, entero, meaning intestines, and itis, meaning inflammation. So this would denote that there is some inflammation of the stomach and the small intestines. But in actual sense, most of the times the stomach is actually even rarely involved if it ever is seen in acute diarrheal disease. And you have some conditions like cholera and even Shigella, which are examples of infectious acute diarrheal syndromes that are not actually even going to be causing significant inflammation in the small intestines, because these are causing a watery type of diarrhea. And especially with cholera, you won't even see the abdominal pains that we see in other kinds of diarrhea. So it's actually much more accurate that we should use the term acute diarrhea as opposed to actually using the term acute gastroenteritis. There is a vicious cycle that is often created in children that have diarrhea, because remember that diarrhea is one of the vicious killers of most children that are below the age of 5. 2 important things you have to keep note of: malnutrition and dehydration. Remember that they're going to be forming this vicious cycle whereby a child is having diarrhea, they're eating inadequately, they're not getting enough fluid. So this is going to tip them into developing malnutrition. And remember that once they have this malnutrition, they are not going to be absorbing the essential nutrients. And even when they're having the diarrhea, they're not absorbing the food materials. There's loss of nutrients. There's going to be increase in catabolism and even improper feeding, rather, that's going to be occurring in diarrhea, therefore aggravating malnutrition. Malnutrition causes some sort of immunosuppression, which can predispose them to infections, which can cause diarrhea. So this creates this vicious cycle in these children. And the incidence as well as mortality is quite high, especially in infants between the ages of 6 to 11 months. Remember, if it is prolonged, it may lead to significant impairment in the psychomotor as well as the cognitive development of young children. How do we classify diarrhea? We can classify it as acute, persistent, and chronic. Anything that is occurring within 14 days with sudden onset, we call it as acute. Anything that starts off as acute but lasts more than 14 days, we call that as persistent. Anything that starts off gradual or insidious and lasts longer than 14 days, we call that as chronic. Another way in which we can classify diarrhea is based on the etiology. Infectious causes or organic causes, which are common, and the bulk majority of them are going to be infectious in origin. It could be bacteria, it could be viruses, which are very common in children. It could be fungi, it could be parasitic. Or indeed non-infectious causes or inorganic causes, which are not so common in children, but they can occur, and they can be a cause of persistent diarrhea. They may also be a cause of chronic diarrhea. Remember, when you talk about acute diarrheal disease, it's an abrupt onset of 3 or more loose stools per day. Infectious causes include the following things. You may have viruses, which are very common in children. Rotavirus has been common among many children, such that we actually even had to institute it in our vaccination program for children. Norovirus or Norwalk virus, cytomegalovirus, enteric adenoviruses, astrovirus, coronavirus, picorna virus, human calicivirus, even HIV are some important causes of viruses that may result in diarrhea. Then the bacterial causes, you have those that cause inflammatory type of diarrhea and those that are not associated with inflammatory diarrhea. The ones associated with inflammatory diarrhea, Campylobacter jejuni, Clostridium difficile, I think this was renamed. And this is an important cause because it's one of the causes of diarrhea that is actually due to antibiotics. Remember, when you give someone antibiotics for some time, it may disturb the normal flora, and then this Clostridium species can actually predominate and can cause what is known as antibiotic-induced diarrhea. You may have Clostridium perfringens, enteroinvasive E. coli, E. coli O157H7, Salmonella, Shigella, Yersinia enterocolitica, Vibrio parahemolyticus. Then you have those that cause non-inflammatory diarrhea like enterotoxigenic E. coli, Vibrio cholerae O1 and O139, enteropathogenic E. coli, even Vibrio parahemolyticus, as well as Staphylococcus aureus. The ones that I have appended an asterisk to, meaning these are causes of bloody diarrhea, so they can potentially result in dysentery. In terms of parasitic, you have Giardia lumblia, you have Cryptosporidium parvum, very common among immunosuppressed individuals, Entamoeba histolytica, which can cause bloody diarrhea, Cyclospora, you have Cyclospora cayetensis, you may have Isospora belli, you may have Balantidium coli, you may have Blastocytis hominis, you may have Trichuris trichuria, and even Stranguloid stercoralis. Some of these are parasitic infections that can actually cause diarrhea. Remember that globally, E. coli is the most common cause of diarrhea, followed by rotavirus. Then you may also have Shigella species and even non-typhoidal Salmonella species. The enteropathogens that are actually infectious, and even just a small amount of inoculum, just a small amount of bacteria, and you ingest it, you can get infected. Things like Shigella, E. coli, enteric viruses, Giardia lumblia, Cryptosporidium parvum, Entamoeba histolytica. These can be even transmitted by person-to-person contact, whilst other things need quite a large inoculum and usually ingestion with contaminated food or water, things like cholera. In terms of the non-infectious causes, you have antibiotics like erythromycin, NSAIDs, you have certain foods and even some malabsorptive syndromes, such as lactose intolerance, where they lack the enzyme lactase to break down lactose. You may have gluten, which is part of celiac disease. Then you have food allergies, those that are allergic to cow's milk, soya. You may have inflammatory bowel disease like Crohn's disease, toxins like tetrodotoxin, which is gotten from pufferfish, botulinism due to improper preservation of food. You may have some surgical conditions like appendicitis or Hirschsprung's disease, or even some endocrine disorders like hyperparathyroidism. Remember that some of these causes may lead to persistent and chronic diarrhea, and it's very important to be cognizant about them because you want to address these things to stop the diarrhea. The majority of the cases of acute diarrhea in children are going to be infectious in origin. Risk factors are those that have a young age. Remember that viral diarrhea is one of the most common things that children are going to be coming to the hospital for. And rotavirus and adenovirus are very common in ages below 2 years. Astro and noroviruses usually infect children that are younger than the age of 5. In terms of Yersinia enterocoliticus, it's typically going to be seen in children younger than 1 year, as well as Aeromonas is going to be this organism that's going to be causing significant diarrhea in young children. You may have some immunodeficiency, such as malnutrition and HIV, as well as certain other drugs, immunosuppressive drugs, that can predispose individuals to developing diarrhea, individuals that develop measles, those that lack exclusive breastfeeding, because remember that there are certain immune factors like IgA that protect you from upper respiratory tract infections as well as diarrheal disease, and these are usually in high amounts, especially in colostrum, the first milk that is produced. Some vitamin deficiency and minerals like vitamin A and zinc can also lead to a patient being predisposed to diarrhea. Now, clinical features largely, and even the clinical syndrome, depend on the infecting pathogen, the dose, and the inoculum. Remember, there are some different causes that will cause a bloody type of diarrhea. There are some things that are going to be causing diarrhea due to production of toxins. Some bacteria are going to be causing damage to, of course, the intestines. Some of them will cause the intestines to release certain, to secrete a lot of water into the lumen. Some of them will impair the absorption of certain nutrients from and certain ions from the lumen, such that the osmolarity changes and you have water flowing in. I won't go into details about the different mechanisms of diarrhea because I think that's a lecture that we'll do in a separate video. So other manifestations are going to depend on the complications that are present, things like dehydration. I talked about dehydration and I said I'll leave it tagged at the end of this particular video. You may have electrolyte imbalances, indicating the nature of the pathogen. The knowledge of characteristics of the consistency, the color, the volume, and the frequency can sometimes help you determine whether this is coming because of a large bowel type of diarrhea or this pathogen is affecting small bowel. Generally, if it's affecting large bowel, it tends to be watery. You have a large volume. A perfect example I can give you is cholera. And they may be blood, but it's never gross. It may be microscopic. The pH is usually less than 5.5. You do have some reducing substances that are present. White blood cells are usually less than 5 per high power field. The serum white blood cell levels are usually normal. Causes are going to be things like viral causes like rota, adeno, caliciviruses, astro, noroviruses. You may even have enterotoxigenic bacteria like E. coli, Klebsiella, Clostridium perfringens, cholera species, Vibrio species, and even some parasites like Giardia species and even Cryptosporidium species. These are going to be causing a watery type of diarrhea. Then those that can affect the large bowel can produce a mucoid or a bloody type of diarrhea, the dysentery, and this is usually in small amounts. There is a high, the frequency is usually highly increased. The blood is usually gross. The pH is usually greater than 5.5. You don't have any reducing sugars. You have the white blood cells more than 10 per high power field. You may have some leukocytosis in your serum white blood cells and even some bacteremia. This is usually seen in invasive bacteria like invasive or enterohemorrhagic type of E. coli, Shigella species, Campylobacter species, Yersinia species, Aeromonas species, and Plasmonas species, and even some toxic bacteria like Clostridium difficile, some parasites like Entamoeba organisms. Now, how exactly are we going to approach a child that has diarrhea? Remember, you want to take a good history, you want to do a physical examination, investigate, and intervene very quickly. Remember that this is somewhat of an emergency because dehydration can actually kill your patients. So on your history, you want to be looking at the details that are surrounding the diarrhea itself. Remember, preliminaries always first. Greet the patient, introduce yourself, get consent from the mother, speak to the patient, greet the patient. Ask about their demographics, very important, because where someone is coming from will give you a hint. If someone is coming from a shanty compound, you know that it's most likely going to be one of these infectious things. So ask about history of the presenting complaint, which will obviously be diarrhea. When did the diarrhea start? Is it associated with meals? What's the duration and the number of stools per day? What's the nature of the stool? Is there any blood or mucus in the stool? The number of episodes of vomiting that are associated, the amount, the color of the vomitus. Is the vomitus projectile or it's non-projectile? Is the child passing less urine than normal? Usually, when was the last nappy changed for this child? Usually a child should produce about 6 nappies or so, and you know that this is a good urine output. Is there any cough? Is there any rash? Is there any abdominal pain or any other significant symptoms like convulsions, recent measles, any attack of crying with pallor in an infant? Is the child able to feed? Is the child able to drink? If they're able to drink, are they drinking thirstier than normal? Are they drinking eagerly? What's the past medical history? Is this the first time this has happened? Have they recently used any antibiotic? Because remember, you're thinking of antibiotic-induced diarrhea. Does this child have cystic fibrosis, diabetes, or HIV, or any other underlying condition that may result in diarrhea? Are they taking any drug, and what's the immunization history? If they're taking any drugs or any local remedies, what drugs were given? Remember, you want to avoid drugs like anti-motility agents in children like loperamide. You want to avoid opioids because these can cause abdominal distension. Ask about the immunization history. Did they receive the rota vaccine? And have they received any vaccines recently? Because sometimes even when you get a vaccine, you may develop some diarrhea as a side effect to the vaccine. What's the nutrition and feeding history? What's the type and the amount of food that they're taking? What's the breast milk? How is the food prepared? Because if it's formula, sometimes you can make the formula too concentrated or too dilute. All those can result in a child having diarrhea. Are they taking any unusual foods? Does anyone at home have diarrhea? Have they been to a daycare? Or have they recently traveled? When you examine this child, you want to get a detailed physical examination that's focusing on the hydration status of the child, especially in young children, because these people can be dehydrated very quickly. So you want to look for signs of dehydration, the general condition. Are they lethargic or unconscious? Are they alert? Are they restless? Are they irritable? Do they have a depressed or a sunken anterior fontanelle? Usually, it's common in infants that are below the age of 18 because it's still open. Do they have sunken eyes? Do they lack tears when they are crying? Do they have dry mucous membranes? Remember, these star signs are not so reliable in a child that has malnutrition, so please be on the lookout. For children that have malnutrition, you want to depend on the capillary refill time, you want to depend on the urine output. And generally, we assume that if a child has diarrhea, we assume that they have at least some dehydration in patients that have malnutrition. Check for the skin turgor. Is it flattening immediately? Is it going back slowly in 1 to 2 seconds? Is it going back very fast, greater than 2 seconds? Are they having any tachycardia? Are they having any hypotension? Are they in shock? You want to look for signs of blood in the stool. You want to look for the signs of severe malnutrition. Do your anthropometric measurements. Is there any features of wasting? Is there any features of edema? Are there any signs of vitamin deficiency? Check for any signs of infections like cough, a high-grade fever, tachypnea, and chest indrawings that may suggest a pneumonia, high-grade fevers with splenomegaly that may suggest malaria, fungal infections that may be suggested by perianal stellate lesions or even oral thrush. Check for any abdominal mass or any abdominal distension. Remember that in these patients that come in and you will see, it's not all the patients or all the children that you have diarrhea that you're going to do a microscopic culture and sensitivity, unless if it is bloody diarrhea. But for the non-bloody diarrhea, usually we don't even order for these routine investigations. So here's a diagram to help you remember the different statuses of hydration. We have children with no dehydration, they have lost less than 5% of their body weight. Those with some dehydration have lost 5 to 10% of their body weight. Those with severe dehydration have lost more than 10% of their body weight. In generally mental status, they are alert, they are well with no dehydration, normal, irritable, or even lethargic in some dehydration, lethargic and apathetic or unconscious in severe dehydration. It's very, very important that you look at the mental status. So mental status plus one of the following things will give you the hint that this child has dehydration or they don't. And the things that you would actually look for that are very important are the mental status, the capillary refill time, and the urine output. So in terms of the eyes, they are normal with no dehydration, sunken with some dehydration, deeply sunken with severe. Their tears are present with no dehydration, and they are decreased in some, and they are absent in severe. Moist mucous membranes with no dehydration, dry with some dehydration, parched with severe dehydration. Normal skin turgor or skin pinch with no dehydration. It goes back slowly, 1 to 2 seconds, with some dehydration, and it goes back very slowly, greater than 2 seconds. Capillary refill time is less than 3 seconds with no dehydration. It may or may not be delayed. With some dehydration, it's delayed by more than 2 seconds. They may even have cold skin. They may have mottled skin with severe dehydration. The pulse is normal with no dehydration, rapid with some dehydration, thready, weak, and impalpable with severe dehydration. Blood pressure is usually normal in no dehydration, decreased in some dehydration, and they may be hypotensive or unrecordable, or they may even be in shock with severe dehydration. Very difficult to distinguish between severe dehydration and shock. I want you guys to comment in the section below how you would distinguish severe dehydration from shock. Then in terms of breathing, normal with no dehydration, fast breathing with some dehydration, and rapid deep breaths with severe dehydration. Urine output is normal for no dehydration, decreased with some dehydration. It may even be absent for more than 8 hours with severe dehydration. You want to know about the level of dehydration because the ultimate management is pretty much the mainstay is fluid replacement. So for those that have no dehydration and some dehydration, you give them oral fluids. Then in some instances, if those with some dehydration can take fluids orally, we can still give them IV, or can even have a mixture of both IV and oral. And for those that have severe dehydration, strictly IV fluids. So for the patients that having diarrhea, sometimes we can manage them without investigations, like I told you, but you want to get a stool microscopy culture and sensitivity. Remember, this is not helpful in management of some cases, except for those that have suspected cholera, those with giardiasis. Remember, you want to identify the parasite. The stool culture is of very little value in routine management of acute diarrhea. And of course, the stool specimen, this is because the culture is going to take about 4 days. You're not going to wait for 4 days. By the time 4 days has elapsed, probably I've already treated this patient. The diarrhea has already resolved or is in the process of resolving. The stool specimen actually should be examined for mucus, occult blood, parasites and ova, as well as white blood cells using a right stain. So remember that the fecal leukocytes, more than 10 per high power field, are going to be suggestive that there's bacterial invasion of the colonic mucosa, although some patients with shigellosis may even have minimal leukocytes at an early stage of infection, as also with patients that are infected with Shiga toxin-inducing and Escherichia coli, as well as Entamoeba histolytica. Remember that the sensitivity is important because you want to decide which antibiotic is going to be targeting this parasite or this bacteria better. So in patients with Shigella dysentery and those that do not respond to empirical antibiotics, you want to do a culture. Then a full blood count should be done to rule out any underlying anemias, systemic infections, or even coagulopathies, urea, creatinine, and electrolytes for electrolyte imbalance, as well as renal function. Remember, these patients may have an anion gap hyperchloremic metabolic acidosis as a result of them losing the bicarbonate in the stool. Other investigations include ESR, abdominal x-rays, and you may also consider barium enema or barium meal in some cases. The management is pretty much fluid rehydration, which is the mainstay treatment. You want to address the underlying cause, zinc supplementation, as well as pain management if they are in pain. So remember that the fluids are usually corrected over 4 to 6 hours. You don't want to do it too quickly, and you don't want to give too much because you may lead or tip the patient into fluid overload. Again, you don't want to wait for so long because the patient may get into an acute kidney injury. So those patients that are in shock and they're unable to take fluids orally, you want to give them IV. But the oral rehydration is usually a preferred method because it will help even stimulate the GIT function. For those that have the malnutrition, remember you don't want to give them ORS because they already have high levels of sodium. The ORS will make things worse. So those that have malnutrition, you want to, in other words, give them rehydration salts for the malnourished child. I covered this in my fluid video. I've done really nice videos on fluid therapy in terms of pediatric patients. And if you don't have the Resomol, you may give them low osmolarity ORS. If they can't take orally, then give them IV Ringer's lactate with 5% dextrose or half-strength diarrhea solution with 5% dextrose. Remember, low osmolarity oral rehydration salts are effective in reducing the stool output as compared to the standard ORS. For those children that are at risk of dehydration from vomiting, you may give them a single dose of antiemetics such as metoclopramide as well as ondansetron. These have been used before and are quite helpful, and I've actually even used some of them in some cases. Not all cases, but some cases. For those that have no dehydration, you encourage the mother to continue breastfeeding. You give them ORS, so 10 mils per kg per loose stool. For those that are less than 2 years, 50 to 100 mils per loose stool. Those that are greater than 2 years, 100 to 200 mils per loose stool. In older children, they can take as much as they can. Remember that you must tell the mother and emphasize that they should feed this or give this ORS slowly, and if the child vomits, wait for about 5 to 10 minutes and then reinstitute it at a much slower rate, because if they take the ORS very quickly, the child will end up vomiting. And remember that the ORS helps in reducing the episodes of vomiting. It also helps with reducing the episodes of diarrhea and replenishes the lost electrolytes and fluid from this baby's body. Then for those with some dehydration, we give 75 mils per kg in 4 hours of ORS. Remember, if they can't take ORS, you can give the same 75 mils per kg as IV, or you can sometimes split IV together with oral, but standard protocol is giving it orally. And then you reassess this child after 4 hours. So if there's no dehydration, we switch them to plan A. Remember, the plan for no dehydration is plan A. The plan for some dehydration is plan B. So you switch them to the plan A, which is the 10 mils per loose stool. Then for those with severe dehydration, we give them plan C. So these must be given IV fluids. And if the child can drink, then you can give them ORS by mouth as you're trying to set up an IV line. It must be a good IV line. We give them 100 mils per kg of Ringer's lactate solution, or if it's not available, normal saline can also work. For those that are less than 1 year, there's a risk of fluid overload, so you give the fluids over 6 hours. For those that are above 1 year, 1 to 5 years, we give the fluid over 3 hours. So you give 30 mils per kg in the first hour for those that are less than 1 year, and 70 mils per kg in the next 5 hours. Then for the children that are between 1 year to 5 years, 30 mils per kg in the first 30 minutes, then 70 mils per kg in the next 2.5 hours. Remember, you don't just start this fluid and go away. You make sure you reassess the patient every 10 to 15 minutes to check if the hydration status is improving, to check if this patient is not being overloaded. And remember, signs of overhydration, you're going to get this cramps in the chest, you're going to get the eyelids swollen, the face may appear puffy, and then of course they may have difficulties breathing. Then you should slow your fluids. Then you can also give them ORS 5 mils per kg per hour as soon as the child is able to drink, usually after 3 to 4 hours in infants and after 1 to 2 hours in children. Reassess the infant after 6 hours and reassess the child after 3 hours. Then you reclassify their dehydration status and you choose the appropriate plan, whether plan A, B, or C, to continue their treatment. In terms of treating the underlying cause, remember we may give antibiotics that may reduce the duration and the severity of diarrhea. They can also prevent complications. For those that have Giardia lamblia, Entamoeba histolytica, Blastocystis hominis, you may give them metronidazole 30 to 40 milligrams per kg per day in 3 divided doses for 7 to 10 days. For those that have Shigella, severe dysentery, and even E. coli associated dysentery, you may give them Cipro 20 to 30 milligrams per kg per day in 2 divided doses, 7 to 10 days. Then for those with E. coli, you may give them trimethoprim sulfamethoxazole 10 milligrams per kg per day of trimethoprim and 50 milligrams per kg per day of sulfamethoxazole divided in 2 doses for 5 days, or Cipro 20 to 30 milligrams per kg per day in 4 times a day for 5 to 10 days. For those that have Cryptosporidium species, paramomycin or even azithromycin 25 to 35 milligrams per kg per day divided in 3 doses for 5 to 10 days can be given. So remember, these agents are quite important to use in some specific cases, and their widespread use has now led to resistance to most of these organisms, so use them with caution. And remember that it's not all diarrhea that is equal to antibiotics. In terms of nutrition and diet, we advise them to continue feeding appropriately. So once the rehydration is complete, the food should be reintroduced. And while oral rehydration can actually continue to replace the ongoing losses from the stool, and the maintenance losses. Then breastfeeding should continue. You provide a minimum of 100 kilocalories per kg per day and a protein intake of 2 to 3 grams per kg per day. With the exception of those that have acute lactose intolerance with diarrhea, most children are actually able to tolerate milk and even lactose-containing diets. You may give them, or actually you should give them zinc, not may, you should give them zinc because it's going to be reducing the duration and the severity of diarrhea. Remember that zinc helps in reducing the morbidity and mortality of diarrhea for that particular episode and for the next 3 months. So it's recommended that all children above the age of 6 months with acute diarrhea should actually receive oral zinc in about 10 to 14 days and after the diarrhea, so about 10 to 20 milligrams per kg. Those that are less than 6 months, give them half a tablet, that's 10 milligrams for 10 to 14 days. Those that are above 6 months, give them 1 tablet, that's 20 milligrams, 10 to 14 days. You can actually dissolve the tablet in a small amount of water, clean water, and then or even expressed milk or even ORS, and then give it to the child. For the older children, they can chew the tablet, or you can dissolve it in small amounts of water, or put it in a cup or on a spoon, and then you can tell them to drink. Now, how exactly does zinc work? So there are some mechanisms. One is that it helps with reepithelialization, so it's going to restore the mucosal barrier integrity and also the enterocyte brush border enzyme activity. Number two, it's going to promote the production of these antibodies and even circulating lymphocytes against intestinal pathogens. So it also has a direct effect of actually blocking an ion channel that is going to be functioning to block potassium being secreted. So it's going to actually be a potassium channel blocker of the CMP-mediated chloride secretion. So it will prevent ions from continuing to be secreted or continuing to being trapped in the lumen and increasing the osmolarity of the lumen. So in this way, the zinc actually helps reduce diarrhea. And remember that it's going to be reducing the diarrhea, the duration, the morbidity and mortality for that particular episode, and like I said, for the next 3 months. For those that are in pain, we often give them analgesics. Paracetamol could be sufficient for the abdominal pain. Remember that there is no role for anti-secretory or anti-motility agents in the treatment of children with diarrhea. How do we prevent this? Usually it's just improving sanitation. We improve our water, we improve our sanitation, we improve our personal hygiene and even domestic hygiene, practice proper hand washing, promote exclusive breastfeeding. Like I told you, exclusive breastfeeding helps prevent in the diarrheal disease and even upper respiratory tract infections because you have those antibodies that are passively passed from the mother to the child. So it will reduce even the intake of potentially contaminated water and food by the child because they're just taking breast milk. So evidence also shows that the HIV endemic populations in developing countries, those that are exclusively breastfed, have a reduced risk of mortality without actually enhancing the rate of transmission from mother to child, especially if they have safe breastfeeding practices. They should also improve the feeding practices and should have safe complementary feeding practices. Vaccinate the children against rota at 6 and 10 weeks, and there are other vaccines that could potentially also reduce the burden of severe diarrhea. Now, there has been recently a new cholera vaccine that has been approved by the WHO. So make sure that you get that if you're in an area where there's cholera. Then mortality in young children is actually reduced by these vaccines. There's a vaccine against Shigella, there's a vaccine against enterotoxigenic E. coli. Now, in terms of chronic diarrhea, remember this is something that started off insidious and lasts more than 14 days. It's a complex condition with many different causes. It may be due to osmotic type of diarrhea, which is seen in lactose intolerance, secretory type of diarrhea seen in cholera. It could be a mixed secretory and osmotic, for example, seen in rota. It could be mucosal inflammation in terms of invasive bacteria or even inflammatory bowel disease or even some motility disturbance. Like I said, I'll talk about these mechanisms in another separate video. Different causes include infections like Giardia, Cryptosporidium, Isospora belli, Microsporidia, and especially in AIDS patients. Non-infectious causes include inflammatory bowel disease, celiac disease, tropical sprue, pseudomembranous colitis, thyrotoxicosis, and diabetes. Clinical features are going to have diarrhea, of course. It may be bloody diarrhea or even steatorrhea. They may have abdominal pains, they may have vomiting, they may have weight loss, they may have anemia. In terms of investigations, you want to get a stool microscopy culture sensitivity to look for the ova and parasites. You want to get a full blood count and an ESR. You may contemplate a rectal or even a jejunal biopsy and a barium enema in some of these patients. The management is going to be largely dependent on the underlying cause. You want to investigate this child adequately. You want to treat the underlying cause. You may give them fluid therapy. Remember, oral fluids should be used, and you should stress the use of this except in those patients that have severe dehydration that you may need to actually put on IV fluids. But even with some that have severe dehydration, oral fluids actually should be given together with the IV fluids. I really hope you enjoyed this video on acute diarrhea. If you did, consider subscribing to the channel, hit the bell notification icon so you never miss on such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.